Hello, everyone. This is Dr. Mikky recording a lecture on Chapter 8, which is the try about the drug administration throughout the lifespan. So here are the learning outcomes or objectives from this lecture. So let's start with the concept of a drug administration during pregnancy and lactation. So first of all, the drug therapy is supposed to run until pregnancy is over, with the exception of serious conditions. So sometimes we cannot see how to outweigh the risk and benefit risk ratio and look at the risk that means from prescribing a medication to a pregnant woman versus not prescribing that medication. So we have to see if the benefit will outweigh the risk for the mother and the baby as well. We have to, take into consideration of the mother's health as well as the baby's health as well. So we have conditions in which that we cannot stop the medication. So these are the exceptions of serious conditions like epilepsy, hypertension, um, um, uh, diabetes. So the type of diabetes that the mothers will or women will develop on during pregnancy is called gestational diabetes. That's a specific type of diabetes, different from type 1 or type 2, called gestational diabetes. That's diabetes that will develop during pregnancy or even infections. So we have to prescribe medications, and we have to be selective in terms of that, to prescribe medications to the mother that are safe for both mother and baby. So be careful when prescribe medications from the same class. Make sure that that medication is highly safe and effective and highly safe for both mother and baby. So 90% of women take at least one medication during pregnancy. And this is just like very simple statistics. They found that 90% of women take at least one medication during pregnancy. So again, we have to must weigh the benefits against the risk. So physiologic changes, we have absorption of drug. Hormonal changes will affect absorption. So during pregnancy, also in terms or concept related to the absorption of drugs, is that the inhaled drugs may be absorbed faster. Concepts pertains to distribution and metabolism, that the changes in cardiac output, plasma volume, regional blood flow, it will change the distribution and metabolism of the drug. Because these are the physiologic changes that you will learn in the maternity and peds course during pregnancy. Drug excretion, that the rate of the excretion of medication may increase. So teratogens, when we say teratogen means the substance, organism, physical agent, or microorganism um, uh, to which an embryo or fetus is exposed, that may result in or cause permanent abnormality in structure or function and cause retardation or death. So there is no absolute teratogens. The risk increases with dose. So once you increase the dose, the risk will increase as well. So these teratogens can be any of this: substance, organism, microorganism, physical agent, even uh, the X-ray or exposure to X-ray, exposure to radiation. All of these may result in the changes to the in the embryo or fetus, either sometimes permanent abnormality in the structure or the function, and that may result in um, disease or retardation or death of the baby. So So during the pre-implantation period, if we divide the pregnancy into three periods, like pre-implementation period, embryonic embryonic period, and then fetal period. So the pre-implantation, which is week 1 to 2 of first trimester, this is most dangerous because the teratogene either causes death or embryo of that embryo, or may has no effect. So it depends on the teratogene. During that first two weeks of first trimester, which is a pre-implementation period, teratogene either cause death or has no effect. Now, with the embryonic period, which is the week 3 to 8, now during this period, 3 to 8 weeks of gestation, that's when the teratogenes, they have a maximum impact on the embryo. And then the fetal period, which is week 9 to 40, or until birth, week 9 to 40 or until birth, that's fetal period. Now, the blood flow increases and placental membranes become more thinner, maximizing substances to transfer to the fetus. So the medications, they will have prolonged duration of action within the fetus. Now, according to the FDA, we said that or medications are classified as in terms of categories A, B, C, D, and X. And give no specific clinical information to help guide nurses or their patients about medications show safety. So if we category A, for example, which is the A in which that there are no increased risk of fetal abnormalities is shown. But however, when the pregnancy category B, it's a B category B drug, then in which that the studies in animals have shown no risk to fetus. So but also no studies done with pregnant women, neither, or the animal studies shown adverse effects, but adequate and well-controlled studies in pregnant women have failed to show risk. So it we can be viewed from different angles. Either we can see category B drugs, which is studies in animals have shown no risk to fetus, but no studies done with pregnant women, or animal studies shown adverse effect, but adequate and well-controlled studies in pregnant women have failed to show risk. However, when we go to category C, in which that the animal studies have shown a risk to fetus, and no studies done with pregnant women, or no animal studies conducted, and no adequate, well-controlled studies in pregnant women. However, in D, risk to fetus shown if benefits outweigh risk may be acceptable. Now, pregnancy category X drugs, that is absolutely contraindicated. So studies done with animals or pregnant women, fetal abnormalities definitely have been shown, and drug contraindicated women who are or may become pregnant. So this is absolutely contraindicated. And this slide shows or presents some of the medications as examples of each drug, the examples of each category. Category A, we have like drugs like the prenatal multivitamins, insulin, thyroxine, which is a hormone for thyroid gland, folic acid. B, under category B, we have penicillin, cephalosporins, azithromycin, like a Z-Pak, and so forth. And then under C, we have more medications. D, some drugs, and then under X, these are absolutely contraindicated. So we have to be careful to prescribe any of these medications under X classification. Clomiphene, isoproterenol, Accutane, fluorouracil, misoprostol, and so on. So factors that affect drug exposure through lactation, time between drug administration and breastfeeding, mother's use of illicit drugs, amount of drug administered. In other words, the dosage of the drug administered. Was it within recommended dosage? Was it an overdose? Amount that reaches fetus tissue. Infant's ability to metabolize drugs. All these are factors that affect drug exposure through lactation. So recommendations for drug use during lactation: administer drug after breastfeeding, teach mother to avoid alcohol, illicit drugs, or tobacco, and also drugs with a shorter half-life are preferable. The drugs with a longer half-life should be avoided. Long half-life should be avoided. And also we will try to select drugs with high protein binding ability and avoid all OTC herbal, the over-the-counter medications or herbal dietary supplements, unless it's being discussed with the prescriber, with the healthcare provider. Now, birth to first 12 months. So safety with child is primary. How child ingest all medications, difficult to estimate how much lost if sped up, and nurse or parent should be aware of special procedures for drug administration. Like, for example, the child should be held or cuddled while medication is administered to ensure the patient, that the baby has administered or has taken all the meds. Period from 1 to 3 years. So you give the toddler, for example, that's a toddler period. So you give the toddler short, concise explanations, provide comfort after that. Oral drugs can be mixed with foods like jam, syrup, puree, and the injections are usually given at specific locations with toddlers. Preschoolers or preschool 3 to 5 years of age. safe storage in which that the medication should be out of reach. School-aged children, which is 6 to 12 years old. Most of the time, I would say, I mean, most children are healthy in this period. And you may have to offer choices when appropriate pertains to the drug administration and timing, and frequency. 13 to 16 years old, adolescent period, and so they need support, they need approval and presence. So we will educate them about the hazards of tobacco and substance and eating disorders, provide important medication information, allow time for the questions, and you allow privacy and control as well. Young adults, you provide medication. You try to ensure the positive medication compliance. So we would educate patients about the substance abuse and treatment of STDs. The middle-aged health changes will begin around 45 years of age. So prescribed drugs for stress-related illnesses. It includes numerous life transitions. Positive lifestyle changes could prevent drug therapy. Commonly, so now older adults. And older adults commonly take multiple medications concurrently in the same time, called polypharmacy. Some predictable ailments or diseases or health conditions, but much variability remains. More adverse drug events in geriatric patients, given the normal physiologic changes to internal organs like kidneys and liver, consistent or consistent with aging process, on a result to the aging process. So there should be reminder aids for administration, maybe can be used and very beneficial for older adults. Reminders, different types of reminders, maintain independence and dignity. Very important for older adults, that they can self-manage their own chronic disease, especially chronic diseases, while at the same time caring and dignity as we interact with them. Absorption of drugs slower in older adults because of the diminished gastric motility, because of the decreased blood flow to digestive organs, and because of the increased gastric pH. Also, there is the distribution in older adults will diminish because of the increased body fat, reduced plasma level, less body water, and then the liver produces less albumin. Which result in decreased plasma protein binding ability, increased level of free drugs, increased level of free drugs, which result in increases potential for drug-drug interaction. As less drugs will be bound to protein, more will be freely floating in the bloodstream and decrease cardiac output. metabolism reduced in older adults, reduced first pass metabolism, which is what we discussed last week in terms of first pass effect, decreased production of liver enzymes, plasma level elevated. So it's this concentrated. Plasma level elevated, this means it's this concentrated. Half-life of many drugs increased. Tissue concentrations increased. Excretion reduction in older adults. Reduced renal blood flow. Reduced GFR, which is glomerular filtration rate. Decreased active tubular secretions. Decreased nephron functions. And decreased drug excretion for drugs processed by the kidneys. So when there is a decreased drug excretion, means that drug will be retained in the body and have more toxic effect. All right, so we'll continue on older adults and provide more detailed explanations about the effect of the medications and drugs on older adults and the physiological changes that involve the pharmacodynamics and pharmacokinetics. Now, the older adults, only 12% of Americans are 65 years of age or older, and then the 12, this 12%, the older adult population, 12%, they consume about 31 or even more percentage of the prescribed drugs. So with the increase in lifespan, however, has come an increase in reliance on medications to maintain health. So the polypharmacy, which we defined earlier, that older adults take more medications than any other segment of the population. Now, among all populations or age groups, the older adults they take the more medications than any other age groups. Now, longevity has resulted due to improved access to healthcare, healthier lifestyle, and more effective medications to treat diseases. So the longevity has increased, the number of illnesses, more use of medications. So that's why patients will have, or older adults will have, this concept called polypharmacy, which is due to comorbidities, too many chronic illnesses, they live with too many diseases, due to use of oral OTCs, which is over-the-counter medications, herbs, dietary supplements, etc. And also because patients may visit multiple MDs and healthcare providers and different pharmacies. And so all these factors could result in what is called the polypharmacy. Too many health conditions, use of OTCs and herbal medicine and dietary supplements, and the patient may visit more than one healthcare provider, more than one pharmacy. So the polypharmacy, the geriatric patients, they experience more adverse drug reactions and drug reactions compared to the younger patients. The response may be different or more severe than what is seen in younger population. So the average, so to speak, is that the average dose may not be safe or effective to the older adult patient as it's in the younger population. And we mentioned some of the physiological changes related to the aging. The anatomic and physiological changes associated with aging may alter the patient's response to medications. So, such as in general, the physiological processes they slow down with advancing age. So everything will be slowed down in terms of metabolism due to decreased GI motility and decrease in GI blood flow. Decreased metabolism due to decreased in hepatic blood flow. Decreased serum albumin due to the decreased albumin production by the liver. Decreased total body water content. Decreased cardiac contractility or contractile force and hypertension due to the increased systemic vascular resistance. Decreased neural conduction velocity, and that will affect the sensory functions like vision, hearing, and smell. Decreased cognitive ability due to decline in brain mass. Decrease in efficacy of the blood-brain barrier. Decreased or the efficiency in the blood-brain barrier. The decrease in renal function due to the decreased kidney or renal perfusion, which results in decreased GFR and decreased number of nephrons. These are all aforementioned changes. These are the physiological processes that have been slowed down with advancing age. So the normal aging processes, the physiological changes of aging can alter and change the pharmacokinetic and pharmacodynamic responses to drugs in older adults. So it's important that we adopt or use what is called the individualization of treatment, which is a very essential concept in prescribing medications to older adults. Each patient must be monitored for desired and adverse responses, and the regimen must be adhered to. So we have to monitor the patient's compliance and adherence to the prescribed regimen. So under the absorption, the altered GI absorption is not a major factor in drug sensitivity. However, the percentage of an oral dose that is absorbed does not change with age. So the percentage of an oral dose that is absorbed does not change with age. Because the rate of absorption may slow, but is usually complete. Delayed gastric emptying and reduced splanchnic blood flow occur. Decreased blood flow to and from the GI tract will slow down. There will be an increase in gastric pH, which will take longer for the tablet and capsule to dissolve. And under distribution, there will be a decrease in the lean body mass, an increase in percentage of body fat, which is the storage deep for lipid-soluble drugs. So the rate of distribution depends on the drug in fat or water-soluble. If the drug is a fat or water-soluble, that makes a difference because of that expected change in older adults, that they will have the increased percentage of body fat. So the rate of distribution of the drug depends on the drug if it's a fat or water soluble. So the lipid soluble drugs like, for example, Valium, phenobarbital, Haldol, these medications will be stored in the tissues with less plasma concentration. So longer periods stored in tissues will cause more adverse effects. Another factor, which is in addition to the increased percentage of body fat, which is a decreased total body water. So the decreased total body water that drugs such as like water-soluble medications like gentamicin, hydrochlorothiazide, abbreviated as HCTZ, hydrochlorothiazide, C diuretic medication. Gentamicin, HCTZ, will have higher concentration in the blood and causing intense responses. In distribution also, there is an element or expected physiological change, which is the reduced concentration of serum albumin. And it may be significantly reduced in the malnourished population or older adults. The plasma protein is reduced up to 13% in the older adult population. Causes decreased protein binding of drugs and increase in the level of free drugs, which will lead to toxicity. And sometimes even older adults may develop the drug toxicity even with regular therapeutic doses of highly protein-bound drugs like Dilantin, Coumadin. So the regularly and routinely prescribed or recommended dosage for adults or younger population, we have to be careful when we prescribe it to the older adults, given the concept of the expected physiological change, which is reduced concentration of serum albumin. So prescribing Dilantin or Coumadin, we have to be careful that the older adults may develop drug toxicity even with regular therapeutic doses of highly protein-bound drugs such as Dilantin and Coumadin. And assess older adults for or adult patients for signs and symptoms of like confusion, drowsiness, reduced cognition, and changes in the altered mental status or changes in the mental status of the patient while on certain medications like benzodiazepines, antipsychotic medications, anti-epileptic drugs. Enter metabolism. The hepatic metabolism declines with age. So reduced hepatic blood flow, reduced liver mass, and decreased activity of some hepatic enzymes will occur in this population or with aging. Produced three main things related to pertinent to metabolism. Decreased hepatic blood flow to the liver, reduced liver mass, and decreased activity of some hepatic enzymes. So the responses to oral drugs may be enhanced, especially the drugs that undergo extensive first pass effect. So the responses to the oral drugs, especially those that undergo extensive first pass effect, they may be enhanced. So half-life of some drugs may increase and responses are prolonged. Like drugs with long half-life, for example, digoxin, gentamicin, acetaminophen, like Tylenol. These medications with a long half-life, they remain longer in the body with potential for accumulation in tissues. So these drugs should be less frequently prescribed and the patient be monitored closely while on these medications. Excretion, the renal function undergoes progressive decline beginning in early adulthood. So the older adult population, they will extremely affected by the changes in excretion. So reductions in renal blood flow, reductions in the GFR, glomerular filtration rate, active tubular secretion, the number of nephrons will decline as well, and the half-life of drugs is increased. So the half-life of the drugs will be increased. The drug accumulation secondary to reduced renal excretion is the most important cause of adverse drug reactions in the older adult population. And this is one of the most important concepts, and that pertains to drug toxicity and excretion in older adults, is that drug accumulation secondary to reduced renal excretion is the most important cause of adverse drug reactions in the older adults or in elderly population. So how to prevent this drug toxicity is that the dosage and frequency of administration should be reduced due to prolonged half-life. And to have a periodic serum creatinine levels. Like, for example, creatinine clearance will decline. So we have to be careful to monitor the patient's serum creatinine levels. So renal function should be assessed with drugs that are eliminated primarily by the kidneys. So we know that this drug is primarily will be excreted by the kidneys. So we have to assess the level of these drugs, assess the effect of these drugs, assess the kidney function test. So in elderly patients or older adult population, use creatinine clearance, not creatinine or serum creatinine, because we have two different types of testing for the kidney function, renal function. We have something called creatinine or serum creatinine and creatinine clearance. I will explain more in class when we get to the kidney renal system to differentiate between the creatinine clearance and creatinine serum creatinine and the bond, and which one is more reliable to assess the kidney function. So creatinine clearance will declines in which is going to be parallel to with kidney function. So in general, that we would know that the kidney function will decline, and we have to be careful when we prescribe or administer the medication that is primarily excreted by the kidneys. That's with the decline in the kidney function and decreased excretion, that the drug will retain and remain in the blood. So one of the techniques or one of the interventions, or at least the assessment techniques, is to assess patients' creatinine clearance periodically. So pharmacodynamics changes in the elderly. In terms of alterations and receptor properties, it may underlie the altered sensitivity to some drugs and the decrease in the number of receptors. So the drugs with more intense effects in the elderly, like warfarin, Coumadin, anticholinergic drugs, certain CNS, central nervous system depressants. These drugs, they have more intense effects in the older adult population. The drugs that has less effective, they are less effective in the older adult, like beta adrenergic agonists and antagonists, like beta agonists and beta blockers. And this decreased effect in the older adult patients because of the reduction in the number of beta receptors. Now let's finally talk about the adherence and compliance among the older adult population or older adult patients. Does the adherence or compliance with the therapeutic regimen one of the major challenges for many older adults? It's the biggest challenge for patients as well as for clinicians. The adherence and compliance, which is the willingness and ability to take medication as prescribed. What are the sources of drug or non-compliance and adherence among elderly to their prescribed regimen? Why they're not taking their drugs as prescribed? It could be due to visual impairment, functional disabilities, or cognitive dysfunction. The drug misuse can be the specific form of non-adherence, which includes either overuse and overuse, underuse, um, or sometimes the patient takes and stop taking the drug, erratic use on and off kind of pattern. So the older adults are high risk for experiencing adverse drug reactions and interactions. And the main reason is that because they take too many drugs, polypharmacy. The average number of medications for a 65-year-old is 4 prescribed and 3 over-the-counter medications, like a total of 7 medications, at least that's the average. So the polypharmacy accounts for 60% of hospital admissions. Polypharmacy accounts for 50% of all medication-related deaths. And sometimes result in symptoms in elderly, often like non-specific, like dizziness, cognitive impairment, drowsiness. So there is something called Beers criteria, BEERS criteria, which includes a list of drugs or medications of special concern for older adults. So the healthcare providers, they should avoid prescribing these medications to older adults because they have these drugs have been found to produce a high incidence of adverse effects in this older adult population. And you will find the updated list um, um, in the book called Beers criteria, BEERS. So the non-adherence among the older adult population, we can promote adherence with unintentional non-adherence. So if that's because we will differentiate between intentional and non-intentional non-adherence among the older adults. To promote the adherence with unintentional non-compliance by like simplified drug regimens, clear, concise verbal and written instructions, appropriate dosage form, clearly labeled and easy to open containers, daily reminders, have some type of social support, any type of support system to help them out, to assist them during the daily activities and taking the drugs on time and if they kind of unable to afford it, find kind of solutions for that. Frequent monitoring for the drug dosage and also for blood labs as well. The intentional non-adherence, which most cases accounts the intentional non-compliance or non-adherence, the intentional one accounts for 70% of non-adherence or non-compliance. So 25% of the cases are non-compliant because of non-intentional, but the 75% they are non-adherent, non-compliant, because this is intentional. And the intentional non-adherence and compliance to the medications is due to, so what are the reasons? Either the drug is too expensive, the drug has too many side effects, or the patient's older adult conviction that the drug is unnecessary or the dosage is too high. So this concludes the lecture on chapter 5. 8.